In this video, we'll cover psychiatric disorders. These are the topics that we'll cover in this video. We'll cover depression, bipolar, psychosis, dementia, and acute agitation. The first topic we'll start with is depression. So when we say depression, we refer basically to three different illnesses. The first one is major depressive disorder. And major depressive disorder can be one single attack or one single episode that the patient experiences, or it can be recurrent attacks of depression. The second type of depressive disorder is what we call persistent depressive disorder, which is also known as dysthymia. The term persistent disorder is actually a new term, and it's used to describe both dysthymic disorder or chronic depression. So both of them are referred to as persistent depression. And patients who have dysthymia have the same cognitive and physical problems as in depression, with less severe symptoms, but the problem is the symptoms are of longer duration and longer lasting symptoms. Dysthymic depressive disorder is also known as neurotic depression. We also have what we call non-specific depressive episodes, which is the third type of depression. And there is also other medical conditions that are associated with depression symptoms. For example, premenstrual dysphoric syndrome, the depressive phase of bipolar, and sometimes even substance abuse, such as alcohol abuse, is associated with symptoms similar to depression. On this slide, we have a list of drugs that can worsen depression. It's a very self-explanatory list indeed. So we have some cardiovascular drugs like ACE inhibitors, beta blockers, hydralazine, methyl-dopa, clonidine, reserpine, digoxin, and thiazide diuretics. Some of the central nervous system drugs such as amphetamines, benzodiazepines, anticonvulsant, L-dopa, barbiturates, bromocriptine, and Haldol or haloperidol. Some antibiotics also are associated with, or they can worsen depression. For example, INH, metronidazole, nitrofurantoin, ethambutol, sulfa-and-tetracycline, and there are some other medications there. So these medications can worsen the symptoms of depression in patients who have depressive disorders. So here let's talk about the diagnosis of depression. According to the Diagnostic and Statistical Manual of Mental Disorders, which is considered one of the most important tools used by psychiatric physicians for diagnosis of different psychological conditions, the depression is diagnosed when the patient has depressed mood, and depressed mood is defined, or it may appear as feeling sad or feeling hopeless, or loss of interest or pleasure in activities that the patient used to enjoy. So one of these two, plus at least 4 of the following symptoms on most days of the week for 2 weeks. So the symptoms are listed here. So the patient must have at least 4 of these symptoms, plus the depressed mood, which is again feeling sad or hopeless, or loss of interest or pleasure, most days of the week for 2 weeks. So these are the symptoms we have here. The patient must have 4 of these symptoms: significant weight loss or weight gain, insomnia or hypersomnia, psychomotor agitation or retardation, fatigue or loss of energy, feeling worthlessness or excessive guilt, diminished ability to think or concentrate or to make decisions, so the patient becomes indecisive, and recurrent thoughts of death, suicide, or suicide attempt if the patient will reach that point. So that's the diagnosis of depression. For dysthymia, the diagnosis is somehow similar. So the patient should have also depressed mood, but instead of having 4 of the symptoms, he will need to have 2 of the symptoms. So as we said before on a previous slide, the symptoms in dysthymia are usually milder, but they are longer lasting. So 2 weeks is not enough to decide that the patient has dysthymia. We need longer duration of symptoms. In adults, the patient must have the symptoms more days than not for 2 years. In children, the patient and adolescent, the patient will have the symptoms on more days than not for 1 year. So in depression, most days of the week for 2 weeks. For dysthymia, in adults, 2 years. In children, 1 year. In depression, you need 4 symptoms in addition to the depressed mood. In dysthymia, you need 2 symptoms in addition to the depressed mood. Here's our first question in this discussion of depression. So the answer for this question, which we just answered now, answer is 2 years. So we just answered this question on the previous slide when we covered the diagnosis. So as a reminder, dysthymia is a less acute but more persistent form of depression. It is more severe. Yes, the symptoms are milder, but the condition in general is more severe. In adult dysthymia, dysthymia symptoms last for 2 years. In children and adolescents, it lasts for 1 year. So the question here is asking specifically about adults. That's why we did choose 2 years. If we change this to children and adolescents, the answer will be 1 year. Next question. And the answer for this question is C. So PHQ-9 stands for Patient Health Questionnaire. The Patient Health Questionnaire is a self-reported version of the bigger assessment tool, the DSM-5. So it's a short version of the DSM-5. The first 2 questions of the PHQ ask about feeling down or losing interest in the last month in activities that the patient used to enjoy. And this actually can be used as a quick screen tool. So please keep this in mind. PHQ is used as a self-reported tool. The first 2 questions of this PHQ, the first question is about did you feel down in the last month? And the second question is, did you lose interest in activities that you used to enjoy in the last month? These 2 questions can be used as a quick screening tool for depression. So on the next slide, we will look at the use of these different depression scales. So Hamilton Depression Rating Scale, or HAM-D7, is 7 items assessment that can be used by the physician to assess the severity of depression and also to assess the remission of depression. The MDQ, or the Mood Disorder Questionnaire, is used for the assessment of manic hypomanic symptoms. It's not used necessarily for depression. Patient Health Questionnaire, which is the PHQ-9, as we mentioned before, is used for self-reporting. And the first 2 questions, just as a quick reminder, question number 1 was, did you feel down in the last month? Question number 2, did you lose interest in activities that you used to enjoy in the last month? These 2 questions can be used as quick self-screening tools. The Edinburgh Postnatal Depression Score is used for depression during pregnancy and postpartum. Other tools that can be used for assessment of depression during pregnancy and postpartum include the postpartum depression screening scale. And of course, the PHQ-9 can also be used in pregnancy. So please just keep in mind, these 3 tools are used during pregnancy. And here we have the PDDS is used for postpartum depression. For DSM-5, this is the big diagnostic tool, and this is the most widely used diagnostic tool by physicians.
Here we will discuss some non-drug measures for depression. So a multidisciplinary approach is important when we manage depression. So we may manage depression using a team of healthcare professionals. This team may include a physician who will diagnose and prescribe medications, and may also include a nurse or a psychotherapist who can educate the patient on how to deal with the depression symptoms. And of course, it can include a pharmacist who will educate the patient on how to take the drug and the drug adverse reactions. Psychotherapy approach is also another important non-drug measure that we use for depression. Psychotherapy, such as cognitive behavioral therapy and interpersonal therapy. So the cognitive behavioral therapy is the CBT and the interpersonal therapy is the IPT. These are used for mild to moderate depression. Each one of these therapies has its own advantages. For example, IPT, interpersonal therapy, as the name implies, it's particularly useful when the patient has significant interpersonal issues dealing with others. CBT has different models. So there are different models targeting specific domains of the disease. So CBT has different models that can be more specific. For example, there is a CBT model that is known as mindful based CBT, mindful based CBT, MCBT. The MCBT is particularly effective in preventing relapse into depression. So this is a specific program or a specific model of cognitive behavioral therapy called mindful based CBT that focuses on how to prevent relapse. Another CBT model is known as acceptance and commitment CBT. It's known as ACT, acceptance and commitment therapy. This is particularly effective in acute depression. CBT and IPT were found to reduce relapse for up to 3 years after completion of therapy. Another non-drug measure we have is light therapy. This is considered first line in seasonal affective disorders such as the winter blues. That's when the patient tends to have low mood in the winter time, and it's used as a adjuvant in major depressive disorder. In light therapy, the patient is exposed to bright light for 30 minutes per day, and the results is usually seen in 1 to 3 weeks. The problem is it has some side effects such as headache, insomnia, and eye discomfort. Even though drug therapy remains the first choice in patients with moderate to severe depressive disorders, a combination of drug therapy for rapid symptomatic relief and non-drug measures appear to be more effective in patients with severe depression or resistant cases. So combining non-drug measures such as the psychotherapy or light therapy along with pharmacological therapy seems to be more effective.
Another non-drug measure that we can use for depression is electroconvulsive therapy. Actually, electroconvulsive therapy or ECT is more effective than any medication that we can use for depression. And the efficacy is about 80 to 90%. So 80 to 90% of patients who will use or receive electroconvulsive therapy will indeed go in remission of symptoms. So someone may ask, if it's that effective, why don't we use it for everyone? And the reason for that is it has high relapse rate. So after using electroconvulsive therapy, we still need to give the patient pharmacotherapy for long-term prevention of relapse. Another important non-drug measure is patient's education. And we can provide the patient with some resources to educate the patient on depression and depression symptoms and how to manage depression. What are some examples for these resources? These resources can be websites like canmat.org website or moodgym.com. You also can provide the patient with self-help books like Mind Over Mood and Feeling Good. CanMat also developed a book that's called Choice D, which discusses the guidelines for managing depression in patient-focused language. So you can provide the patient with these resources in your attempt to educate the patient on depression.
So now we'll start looking at the pharmacotherapy of depression. We'll start with few questions to highlight some of the important principles in pharmacotherapy, and then we will put these principles together in one treatment approach. So now this is our first question. The answer for this question is B. Again, as I said, we will discuss the full approach to manage depression um, just after a couple of minutes. But this slide gives us the first principle in management of depression. If the patient has no response to an antidepressant after a 4 to 6 weeks trial of one agent, the patient should be switched to an agent from a different class. So in our scenario here, in this case, this patient has been on citalopram for 4 to 6 weeks and there is no improvement. So we have to switch this patient to a different class. Citalopram is SSRI. We need to look at something different. So bupropion will be a good choice because bupropion effect is mainly dopamine mediated. So it's a different pharmacological class. Here is our next case to discuss principles of managing depression. So the answer for this question is D. In this case, we have a patient who started on a low-dose SSRI, which is sertraline 25 milligram, that was increased in 1 week to the therapeutic dose of 50 milligram, and the patient responded well. So there was effect. But the patient developed bothersome side effects, which is diarrhea. So the drug is working, but the patient had an adverse reaction. How should we handle this? So generally speaking, according to the Canadian Network for Mood and Anxiety Treatment, which is CanMat guidelines, the patient who responds well to an antidepressant, but the patient has bothersome side effects that doesn't disappear in 2 weeks. That's exactly what happened in this case. The patient had diarrhea and it didn't go away in 2 weeks. The patient should be switched to a therapy within the same therapeutic class between week 3 and week 8. So switching patient to paroxetine in this case would be a reasonable choice. What happened in this case, the patient took sertraline, it did work fine, but the problem was diarrhea. If the antidepressant drug was effective, the problem was side effect, switch the patient to a drug from the same class. Now, let's review the options in this case. So choice A is not a good choice because according to the Canadian Network for Mood and Anxiety Treatment, the CanMat guidelines, once again, a minimum therapeutic dose should be achieved in the first 2 weeks of therapy, and that's exactly what happened in this case. The usual dose of sertraline is 50 milligram, and the physician increased the dose from 25 to 50 milligram within 1 week of initiating therapy. For choice B, taking sertraline on empty stomach is not recommended because actually food increases sertraline absorption by 40%. For choice C, augmentation is used when the patient has only partial response to the antidepressant drug, which you will see on the next slide.
Now we'll talk about the management approach for depression, and this slide summarizes the treatment approach according to the Canadian guidelines. So when a patient is newly diagnosed with depression, we start with a first line agent, and this goes for 4 to 6 weeks. And if we are starting with a low dose to reduce the adverse reactions, we need to titrate to the target dose in the first 2 weeks, and we may even need to go higher if needed. Now, after we start with a first line agent, there are 4 possibilities. The first possibility is to get full response. Full response is defined by improvement in symptoms by more than 50%. If we get more than 50% improvement in symptoms, which means full response, then we continue for the desired duration, which we'll talk about later. There is also a chance that we will get a partial response. Partial response is defined as 25 to 50% improvement in symptoms. In this case, we need to do what we call augmentation. We need to add another agent to the first line agent that we started with to boost its effect. So the best evidence when it comes to augmentation therapy goes to lithium. The best evidence is lithium. But there are other agents that we can use for augmentation. For example, we can use triiodothyronine, which is T3. It was found to be effective. We can also combine the first line agent we use with bupropion. This is also an option. We may also consider short-term atypical antipsychotic therapy. When we consider atypical antipsychotic, we consider quetiapine and aripiprazole, which are approved as second-line agent in the management of depression. However, other atypical antipsychotics also can be used. For example, we can use risperidone, olanzapine, and brexpiprazole. When antipsychotics are used to augment therapy, we use them only for a short period of time. We don't continue for a long time, just short period of time. After we switch agents, if the patient has no response, which is defined as less than 25% of symptoms improvement, we switch the patient to another class, and we continue this for 4 to 6 weeks. If the patient has good response, but the patient develops bothersome symptoms or adverse reactions that persist for 3 to 8 weeks, then we switch within the same class. These last 2 points are important to keep in mind. So if the patient has no response defined by less than 25% improvement in symptoms, we switch to another class. We assume that the first line agent we used and the class of the first line agent is not the best class for this patient. In the second point, if the patient has response, but the patient develops bothersome adverse reactions that persist for 3 to 8 weeks, then we switch within the same class because the class is good. The problem is the agent we used is causing side effects. So if the patient was taking citalopram, we may switch to another SSRI like sertraline. If the patient has good response to citalopram, which is the first agent, but the patient developed bothersome adverse reactions that persist for 3 to 8 weeks. After switching or augmentation, we need to monitor the patient for another 4 to 6 weeks. If the patient has full response, again defined as more than 50% improvement in symptoms, then we will continue. If the patient has no response, then we start thinking of switching again, or we start thinking of combining. Now, combining doesn't happen right away. When do we start combining? We start combining when 2 monotherapy fails. So we try one agent, it doesn't work, we switch to another agent, it doesn't work, so now we try 2 monotherapy. Now we can start thinking of combining. So when we try 2 monotherapy and they fail, we start thinking of combining, or if the patient gets more than 3 episodes of depression, we start thinking of combining. Also, electroconvulsive therapy. We may need to confirm diagnosis, review alcohol intake, review adherence to medication, and check whether the patient is abusing any drug. If the patient fails 3 treatment trials, then we need to refer the patient to a specialist. What is the treatment goal of depression? Our treatment goal is to induce remission and to prevent recurrence. We also would like to prevent suicidal ideation and improve the patient's functions so the patient can go to work and go to school, and improve the overall quality of life of the patient. For how long do we treat depression? So for the first episode of depression, we treat the patient for 6 to 9 months after symptoms resolution. So if it takes 8 to 12 weeks for the symptoms to improve. That's about 2 to 3 months. And then we go for another 6 to 9 months after that. So we're looking for about 1 year of therapy. However, there are some patients who should be treated for at least 2 years when treating the first episode. Which patients need this kind of longer treatment? This is patients who develop severe first episode. So the patients who come first time to have depression, but their symptoms are severe, we will treat them for at least 2 years. Okay, so when you say severe depression, what do you mean by severe? How can I know from the case that this patient has severe depression? The patient is considered to have severe depression if the patient has psychosis, if the patient comes with suicidal ideation, or if the patient comes with severe impairment of the patient's functionality and quality of life. The patient has severe symptoms that doesn't allow the patient to go to work, to go to school, to do his job, whatever this is. So if the patient comes with psychosis, suicidal ideation, or severe impairment of the patient's functionality and the quality of life, in this case, we will treat the patient for at least 2 years. Also, we will treat the patient for at least 2 years if the patient has difficult to treat episode, or if the patient continues to have residual symptoms after finishing the treatment. So we give the patient our 1 year treatment that we mentioned initially, and at the end of the 1 year treatment, the patient continues to have some symptoms. Not many, but the patient continues to have some symptoms, then we may continue for at least 2 years. So to summarize this point again, there are 3 groups of patients who will need to be treated for at least 2 years if they get the first episode. Patients with severe depression, patient who comes with a difficult to treat episode, or a patient who continues to have residual symptoms after finishing the treatment. For second and later episode, we treat the patient for at least 2 years of therapy, and we may start combining pharmacotherapy with cognitive behavioral therapy and interpersonal therapy, and we may consider even longer and lifetime treatment because there is a high risk of recurrence in this case. After that, we do have a summary here of first, second, third line agents. So first line includes SSRI, SNRI, bupropion, mirtazapine, and vortioxetine. Second line includes some new agents like levomelanzapine, and some classical agents like tricyclic antidepressants, trazodone, vilazodone, quetiapine, and moclobamide. Third line agents include irreversible MAO inhibitors, phenelzine, and phenylcypromine. When we combine, how do we combine? We said that we combine agents if 2 monotherapy fails or if the patient has more than 3 episodes. So when we combine, how do we choose? We try to combine something that works on serotonin with something that doesn't work on serotonin. This is to avoid serotonin syndrome. So we can combine SSRI with bupropion or SSRI with mirtazapine, or we can combine SNRI with bupropion or SNRI with mirtazapine. The objective of this kind of combination is to avoid serotonin syndrome by not combining 2 drugs working on serotonin together.
Here we'll talk about the management of depression in pregnancy. So pregnant females usually experience symptoms such as fatigue, lack of sleep, change in appetite, and these symptoms usually overlap with the symptoms of depression. The development of these symptoms, the fatigue, lack of sleep, and change in appetite, the development of these symptoms during pregnancy is an indicator that this pregnant female is at higher risk of postpartum depression. The management, if the female has only mild depressive symptoms, the first choice is the non-drug therapy, either cognitive behavioral therapy or interpersonal therapy. They are used as first line in pregnant females with mild depressive symptoms. If the pregnant female, has moderate to severe symptoms, then we consider pharmacotherapy. So we consider pharmacotherapy in 2 cases. Number 1, if the pregnant female has moderate to severe symptoms, and number 2, if the pregnant female has history of depression. Before starting pharmacotherapy, we need to carefully consider the risk to the benefit ratio. Some of the potential risks are questionable, preterm birth, so there are some concerns about giving birth early. Some cardiac malformations, especially with paroxetine during the first trimester. In the third trimester, there is also an increased risk of pulmonary hypertension. So we have, before we start pharmacotherapy in pregnant ladies who have depression, we need to consider the risk versus the benefit. If we decide that a treatment is required using pharmacotherapy, again, pharmacotherapy is required in 2 cases: pregnant females with moderate to severe symptoms and pregnant females who had history of depression. So after we do the risk versus benefit assessment, if we decide that a treatment is required, we usually start with a low dose of antidepressant. Fluoxetine is considered the first choice. We can use all SSRI, but fluoxetine is the first choice. Paroxetine can be used. As I mentioned earlier, there is a little bit of questionable cardiac risk in the first trimester. We are not very sure that paroxetine causes some cardiac problems for the baby if used in the first trimester, but so far it can be used. Citalopram can be used, sertraline, bupropion, and cypramine. Some data suggest that SSRI may carry cardiac risk in the first trimester, especially paroxetine, as I mentioned. However, we still use them. We need to, if we decide to give pharmacotherapy, we need to taper it prior to delivery, because this will help reducing the withdrawal symptoms and the pulmonary hypertension in the baby. We need to educate the mother on the possible adverse reactions to the baby, such as tremors, feeding problems, and respiratory distress. So the baby who is born to a mother who's taking an antidepressant may have some adverse reactions such as tremors, feeding problems, and respiratory distress. What about breastfeeding? Well, postpartum depression affects about 16% of women after giving birth, and about 80% of women may experience blues, so bad mood and low mood and stuff like that. So treatment may be required. If we want to treat a lady who is breastfeeding, the first choice is cognitive behavioral therapy and interpersonal therapy. So still non-drug measures are considered the first choice in patients with mild to moderate symptoms. If we don't get enough response with the non-drug measures, then or the female has severe symptoms, then we can use an antidepressant. When we use an antidepressant, usually sertraline, citalopram, and escitalopram are recommended for postpartum depression. So citalopram, escitalopram, and sertraline are recommended for the postpartum depression. Paroxetine and nortriptyline, they also appear to be safe, and they have minimal excretion in the breast milk.
Now we'll talk about management of depression in pediatric patients. And managing depression in children can actually be quite challenging. First, the efficacy and safety of antidepressants are not well established in children. Some studies suggest that fluoxetine can be used as first-line agent. Second-line agents can be citalopram or escitalopram and sertraline. Drugs such as tricyclic antidepressant and paroxetine are better avoided if the patient is less than 18 years of age. So this is in terms of efficacy and safety. The second challenge we have is children are at higher risk of adverse reactions. Actually, patients less than 25 years of age who take antidepressants may be at increased risk of suicidal ideation, agitation, and aggression. That's when they take the antidepressants and the patient is less than 25 years of age. When we manage depression in children, we have to also take into consideration other comorbidities. So for example, children who take OCD may benefit from fluoxetine. So we have to see if there is any other comorbidity and select our drug accordingly.
So from here, we'll start looking at some strategies to switch antidepressants. So the answer for this question is
B. Paroxetine tapering may take 7 days. You may think that B and C are the same, but they're not. So B is what we call cross tapering. So basically in B, the patient remains on the first drug and start the new drug at low dose, and then slowly increase the dose of the new drug at the same time of decreasing the dose of the first drug. So one drug is going up at the same time when the other drug is going down, and this is what we call cross tapering. Choice C is calling for the usual tapering. So you stop the first drug slowly, and once you finish the first drug, you start the new drug at low dose. So B is cross tapering, while C is the regular tapering technique. One important point here is that answer B is based on the cross tapering approach that's described in the therapeutic choices. There are other approaches. For example, choice C is also correct. So actually, B is more consistent with the TC, but C is also correct. Um, and this approach is described in books like the RX files and in other guidelines as well. And actually, we'll discuss this further in class. On the next slide, we will have just a brief overview of the cross-tapering technique.
so some strategies to switch therapy we used before to need a washout period, and then we start the new agents, but we now eliminated the need for the washout period by doing what we call the cross tapering. By cross tapering, we mean to start the new drug. We start the new drug at lower dose and start tapering the first drug at the same time, and it usually takes about 1 to 2 weeks. During these 1 to 2 weeks, the new drug reaches the therapeutic dose, and the old drug or the first drug reaches a lower dose, and that's when we stop the first drug. So here is another question on the antidepressant withdrawal, and the answer for this question is E. All the statements here actually are true. So generally speaking, all antidepressants can cause withdrawal symptoms, and the management approach is generally the same. We will now go through the options one by one. So for choice A, reassure the patient that the symptoms will resolve within 3 weeks. That's true. Even severe symptoms will start to resolve within 3 days, but actually it will take 3 weeks to completely disappear. For choice B, this is one way to minimize withdrawal by reducing the dose by 25% every week. This is particularly important for paroxetine and for venlafaxine, which are associated with more withdrawal symptoms than any other agent. If symptoms are bothersome during the withdrawal, the dose can be increased, and then we can start taper the dose but at a slower rate. So instead of 25%, we can go even lower than 25%. We also may switch the patient to fluoxetine, which is in choice C, and then slowly withdraw the fluoxetine, because fluoxetine has the least withdrawal symptoms because of its long half-life. So choice C is to switch the patient to fluoxetine. For choice D, symptoms usually appear within 1 week of discontinuation of therapy. So symptoms appear within 1 week of discontinuation of therapy, and symptoms will start to improve by day 3. However, it will take 3 weeks for the symptoms to totally disappear. Another important measure is to educate the patient that the withdrawal symptoms are not serious or life-threatening. Yeah, they can be severe sometimes, but this doesn't necessarily mean that they are serious or life-threatening. The withdrawal symptoms and how they are managed are described in details in the SSRI monograph.
We'll have a couple of notes on discontinuation syndrome. The first and the third one were actually already mentioned on the previous slide. So if the symptoms are bothersome, the withdrawal symptoms or the discontinuation symptoms are bothersome during the withdrawal phase, we can increase the dose and then start tapering again at a slower rate. So for example, if the patient was taking citalopram 20 milligram and the patient reduced the dose to 10, and then the patient reduced the dose to 5, so we are tapering the drug, but at 5 milligram the patient started to have withdrawal symptoms, we can increase from 5 to 10. So we increase the dose to the lowest dose when the patient had no symptoms. So we increased from 5 to 10 because the patient had no symptoms at 10. The patient only developed symptoms when we taper to 5. So we go back to the higher dose of 10 milligram and we start tapering at slower rate. So instead of going from 10 to 5, we can go from 10 to 7.5. Instead of reducing the dose, for example, every week, we can reduce the dose every 2 weeks, and so on. The second point is also important. It takes 6 weeks of antidepressant therapy to precipitate discontinuation symptoms. What does that mean? If a patient, for example, took citalopram or took paroxetine for 3 days or for 1 week, and the patient comes and say, well, I don't like this medication, I don't want to take this medication anymore. The patient only took it for 1 week. Should we be concerned now over withdrawal symptoms? Should we be concerned that the patient may develop discontinuation syndrome? The answer for this is no. Why? In order for the patient to develop this discontinuation syndrome, the patient should take the antidepressant for 6 weeks. This is enough time for the body kind of to get used to the medication, so the patient develops withdrawal symptoms or discontinuation symptoms. Finally, short-acting drugs such as paroxetine, and we also said venlafaxine, they have higher risk of withdrawal symptoms. More information about these withdrawal symptoms will be under the SSRI monograph.
Now, another important question is how to differentiate between withdrawal symptoms and relapse. Why is that? Because when the patient discontinues the antidepressant and the patient starts to have some symptoms, the patient may think that the depression is coming back, but actually what the patient has is withdrawal symptoms. Or maybe it can be vice versa. Maybe the patient doesn't have withdrawal symptoms and this is relapse of depression. So here we have some, on this slide, we have some withdrawal specific symptoms. And this include dizziness, headache, nausea, electric shock sensation, and rushing sensation in the head. And as we mentioned, that's the resolution usually starts within 3 days, and it will disappear within 2 to 3 weeks. So that's an important one. So when the patient comes to you saying that I still do my antidepressant and I think my depression is coming back, you need to ask specifically about the symptoms that the patient has, such as dizziness, headache, nausea, electric shock sensation, and rushing sensation in the head. Another very important question to ask is, when did the symptoms start? Withdrawal symptoms usually appear within 1 week after discontinuing the antidepressant, while relapse symptoms takes 2 to 3 weeks to appear. So very important to ask about the onset of symptoms. We all know that MAO inhibitors have lots of drug-drug interactions, and some of them are actually contraindications. So this question is asking about drugs that are contraindicated in patients taking MAO inhibitors. And the answer for this question is B. So ipratropium inhaler and tiotropium inhaler are contraindicated in patients taking MAO. And the reason this is interesting, because we don't usually think about inhalers as drugs that may interact with systemic agents, because you may think the absorption is very minimal. Cyclobenzaprine is contraindicated. Atomoxetine, amphetamines, and methylphenidate, the drugs that are used for ADHD, are also contraindicated. And as you know, all sympathomimetic drugs such as the decongestants, either nasal or systemic decongestants, should not be used in patients taking MAO inhibitors. Lithium is not contraindicated. Like Lexicon drug interactions says it is a serious interaction, but it doesn't mention it as a contraindication. It just says that it requires monitoring. Phenelzine monograph, which is one of the MAO inhibitors, does not even mention lithium as a drug that's interacting with MAO inhibitors. Here is a little bit detailed list of medications that can cause serious drug interactions with MAO inhibitors. Now, I just want to bring a couple of medications here to your attention because this can be very tricky. So some of the drugs that we usually don't think about them. One is linezolid, for example. That's a tricky one. Why? Because linezolid is an antibiotic. When we talk about antibiotic, you wouldn't think that any antibiotic would have a MAO inhibitor-like effect. And actually, linezolid, which is an antibiotic, is a MAO inhibitor. So linezolid with SSRI can cause serotonin syndrome. It has the same kind of serotonin syndrome warning. So that's a drug that we wouldn't think about it too much. Another drug that you may not think about is dextromethorphan, because dextromethorphan is a cough syrup. It's available over the counter. Patients take it OTC, but actually they do interact with MAO inhibitors causing serotonin syndrome. Some other medications, something like the triptans, the ones that we use for migraine. We are all very familiar that MAO inhibitors should not be taken with other sympathomimetic drugs, should not be taken with other antidepressants, but there are some medications that you need to be more mindful of.
There are some natural medicine that we can use for depression. However, all the natural medicine we use for depression are used as second-line agents for mild to moderate symptoms. So the natural medicine that we can use include omega-3 fatty acids, and the dose is usually 1 to 2 grams per day. And patients who take this kind of dose of fatty acid, of omega-3 fatty acid, commonly experience upset stomach, and they also may have kind of fishy aftertaste. And it's also worth noting that omega-3 fatty acid may interact with oral anticoagulants and increase the risk of bleeding. The other natural medicine that we can use is the S-adenosyl L-methionine, and it's known as SAMe. And this medication has some adverse reactions. For example, it can cause some insomnia, some constipation, some dizziness, some dry mouth, and sweating. And there are some reports of increasing anxiety and mania or hypomania in patients who have bipolar disorder. So it may worsen bipolar disorder. In terms of drug interactions, SAMe also may interact with oral anticoagulants and can increase the risk of bleeding. And the S-adenosyl L-methionine can also cause serotonin syndrome if it's taken with serotonergic drugs. Vitamin D and folic acid, they were tested, but they were not effective. And there is the ingredient that's L-methylfolate. L-methylfolate was found to augment the effect of SSRI, and it was found to be more effective than placebo in augmenting the SSRI effect. And of course, the most important natural medicine we use for depression is St. John's wort, which we'll discuss on the next slide.
We will certainly need to talk a little bit more about St. John's wort. So the plant itself is called Hypericum perforatum. The medicinal ingredients is what we call hypersine or hyperforin. It has other ingredients that may contribute to the pharmacological effect, but these two, the hypersine and hyperforin, seem to be the most effective active ingredient in the plant. The mechanism, St. John's wort inhibits the reuptake of serotonin. It also increases the serotonin receptors. Other effects include increasing norepinephrine release, increasing dopamine, and increasing GABA. That's why they believe it has some anxiolytic effect. It inhibits MAO and dopamine hydroxylase enzyme, and it binds to the opioid sigma receptors, which contribute to more of the antidepressant effect as well. In terms of using St. John's wort, it is used in patients who have mild to moderate depression. In mild to moderate depression, St. John's wort can be as effective as SSRI. It's also used in premenstrual syndrome, smoking cessation. It's used topically for dermatitis and myalgia, used for obsessive compulsive disorders, for seasonal affective disorders. It has some antiviral effect, antibacterial effect, and anti-inflammatory effect. But of course, we all know that St. John's wort is mainly used as an antidepressant. It has some advantages over other agents. For example, it has no significant effect on the blood pressure, or so it's not like, for example, SNRI, venlafaxine, that increase the blood pressure. They are not, St. John's wort is not like tricyclic antidepressants that cause hypotension. Also, St. John's wort lacks any anticholinergic side effects, so that's an advantage over tricyclic antidepressants, which have significant anticholinergic side effects. There is no such adverse reaction such as anorexia, such as insomnia, sexual dysfunction, excessive sweating, and visual disturbance, and these are common with patients who are taking SSRI. Adverse reactions are milder in nature and include gastrointestinal symptoms, photosensitivity, and agitation. These are the most commonly reported side effects, and we have to stop St. John's wort 2 weeks prior to surgery. In terms of drug-drug interactions, St. John's wort can cause serotonin syndrome because, as we said, it can increase the level of serotonin. It also has some MAO inhibitory effect. So, as anticipated, any drug that can increase the level of serotonin, like SSRI, tricyclic antidepressant, SNRI, all the ones that interact with MAO inhibitors may also interact with St. John's wort. It also interacts with digoxin, warfarin, antiretroviral drugs, the ones for HIV, methadone, tacrolimus, oral contraceptive, and cyclosporin. There are no studies in pregnancy. It appears to be safe, but there is no evidence, and that's why we should avoid it. And it appears to be compatible with breastfeeding.
Here we have few final notes about depression. So what should we do if the patient comes to the pharmacy complaining of suicidal ideation, or we find that the patient has suicidal ideation? Of course, referring the patient to the physician is very important. However, this may take time. So until the patient is able to seek the necessary medical advice, it may be a good idea to give the patient the contact information for the depression crisis line. Depression crisis line is a 24-hour support service that provides support to those who are going through severe depression until they are able to see their physician. Another point is counseling. Pharmacists should counsel the patients to take their medications daily and to continue taking the drug even if their symptoms improve, and to educate the patient on the delayed response to antidepressant drugs. So it takes 2 weeks to see some improvement in the sleep and appetite, and 4 weeks to see improvement in the mood, and to provide the patient with resources. Suicidal ideation is higher in children and young adults, and we mentioned that before, that patients younger than 25 years of age tend to have higher risk of suicidal ideation, aggression, and agitation. From all the antidepressants, there are a couple of meta-analyses that were conducted, and they show that escitalopram and sertraline, they appear to be the best choices among antidepressants. Of course, we have so many other medications like antidepressant drugs that we can use, but meta-analysis found that these two agents, escitalopram and sertraline, appear to be more effective than others. Stimulants, like CNS stimulants like methylphenidate and amphetamine salts, they don't affect depression symptoms, but they may improve the lack of energy that some patients may experience. But in terms of depression symptoms, stimulants don't have effect on depression symptoms.
Here is a slide that talks about the management of depression in patients who have other symptoms. So, for example, if the patient has depression and insomnia, mirtazapine, trazodone, nortriptyl, fluvoxamine, which is the most sedating SSRI, or paroxetine, can be used. From experience, I can tell you that trazodone is highly used in insomnia, especially in depressed patients, but many patients will take trazodone, especially elderly, for insomnia. Mirtazapine also causes significant sedation as an antidepressant, and it can also help in patients who have insomnia. If the patient has depression and migraine, amitriptyline and nortriptyline are good choices in this case. If the patient has obsessive compulsive disorders, clomipramine and SSRI will help for both conditions. If the patient is obese, SSRI are good. Paroxetine, we have to, put a question mark beside it. Bupropion, venlafaxine, and duloxetine are okay to use. We need to avoid mirtazapine. Why? Because mirtazapine is associated with significant weight gain. Epilepsy, SSRI, trazodone, venlafaxine, moclobamide can be used, but we need to avoid bupropion. Bupropion, as you know, is contraindicated in patients who have history of seizures. For smoking, if the patient is a smoker and has depression, bupropion and nortriptyline will be a good choice. If the patient has phobia, and we'll talk about this under anxiety, MAO inhibitors and paroxetine are good choices. If the patient has sexual dysfunction, bupropion is associated with the least sexual dysfunction among all the antidepressant agents. The second topic we have in this discussion is bipolar.